Hi, this is Sue. This screencast continues our discussion about CVADs, which stands for Central Venous Access Devices, more commonly called central lines. I'll be describing 3 procedures used with central lines: flushing, drawing blood for lab work, and doing sterile dressing changes. When central lines are capped without an IV fluid infusing, just like peripheral saline-locked IVs, they need to be flushed routinely to keep them patent. When central lines are flushed, we always have to use a 10 ml syringe or larger, both when checking patency by aspirating and when flushing. A smaller syringe would create too much pressure. I think I mentioned that in the last video, and it can rupture the cannula. Another important aspect is all air needs to be removed from the syringe prior to pushing anything into the central line. And that's very important to prevent an air embolism, which could be very, very dangerous for the patient. Even with pre-filled syringes, like the ones in the picture in the upper corner here, they have air, and then the air needs to be purged from the syringe before we inject any fluid into the patient. Central lines are flushed on a routine basis. Usually it's every 6 to 12 hours, depending on the protocol of the facility. And they also need to be flushed before and after accessing the line if it's capped off, if it's saline locked. The way we do that is we check patency by gently flushing with a small amount of fluid and looking to make sure that that the flush isn't blocked, and also aspirating and looking for a good bright red blood return. Sometimes when you try to aspirate, it's difficult to aspirate, but you still may be able to flush easily. And you may still be able to use that port. It depends on the facility's policy. But what happens sometimes is a flap of fibrin forms over the tip of the cannula, so that when you pull back to aspirate, it pulls the flap closed over the hole or the opening of the cannula, yet when you flush fluid forward, it goes in gently. So depending on your policy, even if you can't aspirate, sometimes you're able to use that line anyways. The amount of saline to flush with depends on the facility's policy. It's usually 10 mLs. It may be as much as 20. And depending on the type of central line, you may have to put heparin in it as well. When you flush it, you need to use a vigorous push-pause technique. This is after you've checked placement. Remembering that the purpose of the flush is to create turbulence, to remove any fibrin that's building up in the cannula, and to remove any medication residue or anything that's building up inside the cannula. So it's a pretty aggressive push-pause technique to get it to flush. When you're flushing the line, if you feel resistance, stop. You don't want to create an embolism. And you can reposition the patient and try again. You can turn them on their side, raise the head of the bed, or lower the head of the bed some. Because what happens sometimes is the cannula can get pinched off between the clavicle and the first rib. And if you reposition the patient, that may release that. Another rule with central lines is to always use a new syringe each time the line is accessed. So once you withdraw a syringe, if you need to flush again, you never use the same syringe. And that's for infection control, which is crucial with central lines. For the same reason, we use a new antiseptic swab every time the line is accessed. So even though the swab may still be wet, we use a new one every time we clean the hub. And remember, the hub needs to be cleaned according to your facility protocol, but generally it's at least 10 to 15 seconds. Infection is a big concern, so we take special precautions. Another precaution to prevent air embolisms is the pigtails on a central line need to be clamped when they're not in use. And you can see the picture in the lower left, the little blue clamps there. In this picture, the clamp is open. But the purpose of the clamp is if the cap on the end comes off by accident, air can't get in and create an embolism. Now, some caps or valves are made so that they need to be left unclamped for the pressure to be correct in the cap. So you need to know what type of cap and what the procedure is at your facility. In our lab and our facilities, we clamp the pigtails when they're not being used. The second procedure I want to talk about is drawing blood from a central line for lab work. The equipment that you will need, again, the first thing you should do is read your facility's policy and find out the amount of saline that's required to flush both before and after withdrawing the blood, and the amount of blood that gets discarded before the lab blood is drawn. So you will need, depending on the amount of blood that you need, how many tubes you need to fill, you'll need 2 to 3 10 milliliter syringes with normal saline, 1 to 2 empty 10 milliliter syringes, or a Vacutainer adapter that attaches to the pigtail, and I have a picture of that in a minute. Heparin, if needed, per your agency policy. And remember, if you are using heparin, you may only be infusing a few milliliters, but it needs to be given in a 10 milliliter syringe, again, to prevent rupture of the cannula. You need antimicrobial swabs, gloves, and protective glasses. The gloves are not sterile gloves, just exam gloves to protect yourself as part of standard precautions. And you need the appropriate blood tubes for the labs that you that have been ordered. Sometimes the tubes get sent up from the lab. Sometimes we find them in the clean utility room, and usually there's a chart that indicates which color tube is needed for which lab that we're going to draw. Also, you need to print off patient labels for each tube, and it's important that you have those before you draw the blood, because blood samples need to be labeled at the bedside, and if they're not, then they have to be discarded and redrawn. Check your physician's orders so that you know which labs you need to draw. Identify your patient with 2 identifiers and explain what you'll be doing. And then if they do have IV fluids infusing into any of the other pigtails of the central line, you need to hold them for 1 minute. If they're on a pump, you can pause the pump. If they're on a piggyback, you can pause the piggyback. And if you're infusing TPN or lipids or heparin, they need to be paused for 5 minutes before we can draw a lab. Then wash your hands, put on the non-sterile gloves and your protective glasses, and identify the distal port, which is typically the port that's used to draw blood from. But find out what your facility's policy is for the blood draws. The way that you know which port is which is they should be labeled on them. Sometimes you can tell by the length of the pigtail, but the best way to identify it is to look on the pigtail itself, like in this picture with the red circle on it. And then clamp any other ports that you're not using, if that's the protocol, so that the blood sample comes only from the pigtail that we're drawing from. Then you scrub the hub of the central line using good pressure and friction, scrubbing the top and also the sides and the threads of the port. Then you insert a 10 milliliter syringe with normal saline flush into the port and check patency of the CVAD by pulling back on the syringe and aspirating for blood return. Then you flush using the push-pause technique, creating that turbulence. Then we need to withdraw 5 to 10 milliliters of blood, depending on your facility's policy, and discard it. And that's to remove all the saline that we just flushed the line with, so that the blood that we use for our lab sample is not diluted. And you can use the same syringe that you flushed with if you don't remove it from the hub. So after you do your push-pause flushing, just leave the syringe on, pull back, and withdraw the 5 to 10 milliliters of blood and discard it. Then you need to scrub the hub again with a new alcohol swab for 10 to 15 seconds and insert a new 10 milliliter syringe that does not have saline in it and withdraw the required amount of blood for the lab sample that you need and transfer it to the blood tube. And in this picture you can see the syringe with the blood on it is attached to a vacutainer, and the blood is just pulled into the vacutainer. In this case, depending on how many vials you need to fill with blood, you may need more than one 10 milliliter syringe to withdraw blood samples. And remember, you can't reuse the same 10 ml syringe. You need a new one every time you access the port. Or if you have the appropriate vacutainer blood transfer device, you can screw it directly onto the central line port and fill the blood tubes from there. And that's what you see in the picture on the lower left. The vacutainer transfer device screws right onto the port. And the benefit of that is that you don't need syringes, multiple syringes, if you have multiple vials to fill. You can fill them off the same blood transfer device. After you've completed the blood draw, you need to flush it again, depending on the agency protocol. It's usually 10 to 20 milliliters of normal saline, so you may have 2 syringes of saline flush for that. And remember again to use 10 ml syringes to do that. When you're finished, unclamp any ports that will be used for fluids and restart any IV fluids that need to be run. Label the tubes at the bedside with the date, the time that you drew the blood, and your initials. And like I said earlier, that needs to be done immediately at the bedside. If you don't have the labels, the blood would need to be redrawn. And send the blood to the lab as soon as possible so that it can be run. The next procedure that I want to describe is a central line dressing change. Central line dressing changes are a sterile procedure to minimize the risk of infection, very important. And they are usually done weekly and as needed, but you need to find out what your facility's protocol is for that. Most of the equipment you need usually comes in a prepackaged kit. It will contain sterile gloves, a mask, some type of antimicrobial solution to cleanse the skin with, and a clear tegaderm or opsite dressing. In addition to that, you'll need non-sterile exam gloves. You'll need an extra face mask. And if your facility uses bio patches, you'll need one of those as well. And at the bottom of the picture, you can see the bio patch. It may come in the dressing change kit, but usually comes separately in a small sterile package like the one that you see. So for the procedure, the first thing you need to do is hand hygiene, clean your hands, and then open the sterile package on the over bedside table that you've pulled close to the patient. If you do use bio patches, you need to open the package and flip the bio patch onto the sterile field. Then place the extra mask that you brought with you on the patient and have them turn their head away from you. And that's to not breathe on the site of the dressing change. Then put on the non-sterile exam gloves and remove the old dressing, being careful to stabilize the catheter with one hand, and pull the dressing towards the insertion site, again to help prevent it from being dislodged. Now the central lines are usually sutured in. You can see those two little wings with the holes. It's not sutured in on this mannequin. Usually it's sutured in on the patient, but you still need to stabilize it to make sure that those don't come out. Once that dressing is off, remove your exam gloves, wash your hands or use hand gel, and put on your sterile gloves. Then if you have a sponge with antiseptic to clean the skin, squeeze the tabs together on the side and the foam gets saturated. Then scrub well around the insertion site and over it and over the hub using back and forth friction over a 4 to 6 inch area. So you're scrubbing over quite a large area. Let the antiseptic dry completely so that it does its job. And at that point, if you're using a bio patch, you need to apply it to the insertion site. If it has a blue side, the blue side goes up, and you make sure that the edges of the slit in the bio patch are touching. The bio patch has a slit along one end, and that's how you can put it over the cannula or over the catheter. Then apply the new clear dressing and smooth it down so that there are no wrinkles in it, making sure that you cover the insertion site and hub completely. Then you want to carefully remove the paper frame from around the dressing and apply a label with your initials, the date, and the time that the dressing was changed. And with many clear dressings, the label is part of the frame, the paper frame that goes around the dressing. If not, you need to find another label to put on it. And this is a picture of a central line that's dressed correctly with the bio patch with the blue side up. Now some facilities also have you change the caps on the end of the pigtails when you do the sterile dressing change as part of the procedure. And so you would need to find that out and find out their procedure for doing that. But generally you clamp the lumens of the pigtails, remove the old caps which screw off, scrub the end of the cannula, so the open end of it, for 10 to 15 seconds, and let it dry, and then screw on a new cap. So find out if that's part of the procedure. And that's it for the dressing change. One reminder I wanted to give you is that discontinuing central lines is not in your scope of practice yet. RNs can do it, but in our program you're not taught to discontinue central lines until the second year of the program, and so it's not in your scope of practice until you have been taught it. And in Colorado, working with central lines is generally in the scope of practice of LPNs, but discontinuing central lines is not. Remember, with central lines, aseptic technique is vital, as is the prevention of air embolisms. So good aseptic technique and sterile technique when doing a dressing change, and no air in the syringes, and being very careful to clamp the pigtails. That's it. I'll see you in the lab.